I'm the least interesting speaker here today anyway, so if they miss it, that's fine. Good afternoon, everyone. It's a real pleasure to welcome you all to this session today. Before we get started, I would like to give a big thank you to our sponsors, GIZ, the German corporation, Deutsche Zusammenarbeit, my German is pretty okay, Washington Schools Network, and of course the organizers, the UNC conference themselves, for supporting us and organizing this session and bringing so many people together to talk about this important topic. And that topic is menstrual health at scale, the public sector's role in ensuring choice, access, and social support. So in recent years, there has been an increasing attention on the systemic gaps in addressing menstrual health and hygiene across both humanitarian settings and in low and middle income countries. Yet scaling effective interventions really remains a challenge. So the underlying structures that can ensure equitable access to menstrual products, information, and infrastructure for all are too often left unaddressed. And if we are serious about removing the barriers that hundreds of millions of menstruators are experiencing every month, public sector actors need to fundamentally shift their understanding of the problem and the role that we can play in overcoming it. So with the support of UNFPA, UNICEF, UNHCR, the World Bank, and the Reproductive Health Supplies Coalition, we organized today's session so we can have a critical review of how public sector actors can address menstruation at scale. Now, we will start this session with 4 different speakers, each representing a different public sector actor. And in the second half of the session, our speakers will be joined by experts from related public health and sexual reproductive health fields who will share their insights and experiences to give us a unique perspective on the way that menstrual health and hygiene can be accelerated and how its impact can be scaled. Before we start with the first speaker, I would just quickly like to say that any questions and comments that you have can be posted in the chat. Now, the chat is not on Zoom, but is on the conference page for this session. So please navigate there if you have any questions, and we will address these questions after the 4 presentations have taken place. I hope we can squeeze it all into 1 hour and 15 minutes. That's why I will stop talking now and hand over to our first speaker, Danielle German from UNFPA's Humanitarian Office in Geneva, and I'll let her introduce herself and the role that she fulfills there. Over to you, Danny.
Hi, yes, as said by Adrian, my name is Danny German. I am the Humanitarian Supplies Analyst with UNFPA's Humanitarian Office in Geneva. Together with UNHCR, I'm also the co-founder of the Menstrual Hygiene Management in Emergencies Working Group. In my presentation, I'll be looking at the potential role that humanitarian actors can play in driving progress for menstrual hygiene supplies specifically, beyond just a humanitarian crisis response. Next slide. Before we start looking into the specific ways that humanitarian actors can contribute to the wider efforts to scale MHM interventions for supplies, I wanted to first highlight why and how humanitarian actors are contributing to MHM supply availability and quality. So what is the problem that humanitarian actors are facing? There's a structural absence of a range of high quality menstrual products for menstruators living in fragile and crisis-prone low and middle-income countries. Menstruators are not in a position to manage menstruation with a high-quality product they want to use and can afford. Emergencies can compound these pre-existing challenges by further exacerbating certain risks and vulnerabilities. At the same time, emergencies can weaken already fragile supply chains and markets for menstrual products, further limiting availability and choice. When trying to support the needs of affected populations, humanitarian actors are therefore limited in their ability to provide quality and variety of products for the populations that we serve. But humanitarian actors can contribute to a structural solution to this supply gap. Next slide. The overall objectives of humanitarian actors in addressing MHM supply are to be able to meet both the immediate needs of populations during or after crisis, through the provision of a range of high-quality products, and by working to support the national supply chain to recover and quote-unquote build back better, improving overall quality and availability and choice long after the humanitarian response has passed. We endeavor to do this by focusing on a few different things. First of all, being speed. We really need to reinforce how we can ensure the fast availability of products after an emergency like a natural disaster or the onset of a conflict. We can do this through either international or local procurement. We also need to look at quality. So how can we ensure availability of high quality products, particularly when the local market might not have had that before the emergency strikes? We also need to be looking at method mix, very familiar for those of us who work in contraceptives, but how do we ensure informed choice, mirroring what we've done in contraceptives by looking at a method mix model before the emergency strikes and then being able to leverage on that during the emergency response. We need to be aware of being non-duplicative and ensuring that no one is being left behind. So ensuring that there's sufficient coordination among the different actors working on MHM in supply distribution. We also need to be thinking about supply chain strengthening and then, of course, waste management. However, the sector is still working to fully be able to meet these objectives, and humanitarian actors are often there only for a short time, meaning that we cannot achieve these objectives alone. Next slide. Ensuring availability, quality, and demand of menstrual products as part of a humanitarian response comes with a number of logistical and programmatic barriers. As part of the early days of a humanitarian response, humanitarian actors are required to make a lot of assumptions about population demographics and needs based on limited pre-crisis data and global demographic estimations. We also have to consider changing needs for specific populations like persons on the move. This means that our ability to understand community preferences and needs is more limited and reliant on pre-crisis data. There are also a large number of actors coordinating response across different sectors related to MHM, health, WASH, protection, etc. This means there are a lot of actors to coordinate in interventions. The intersectoral nature of MHM means that you end up with many procurers of the same product serving the same population, with products of varying quality and varying regularity in distribution. This is unlike many other items provided by humanitarian actors related to health, because these have much more limited global and local regulation. Humanitarian actors are often as well the sole providers of MHM supplies, again with differing qualities and differing method mix. In many places, there are often weak pre-existing markets, again offering that same differing quality and differing method mix before the emergency. This means that there's a general lack of quality options through local procurement to be able to provide a product at scale required. While local procurement is a generally more sustainable option, and while there are smaller manufacturers who can meet quality standards, it's difficult when you're looking to then apply this at scale, either within a country or across many countries. And then there's also an increased trend toward cash and voucher assistance, which is generally good, but this does require strong local markets and market-based programming, which are not often prioritized for MHM. Finally, even when supplies are available, cultural practices, beliefs, and stigma may inhibit menstruators' ability to manage menstruation. Next slide. Humanitarian actors have a lot of potential to help drive wider progress on menstrual hygiene supply availability and quality beyond just the humanitarian response. Starting on the left, we have some foundational ways that humanitarian actors can support this. First of all, when a humanitarian crisis strikes, there's often large media attention and donor attention, with the potential to conduct advocacy and draw attention to often pre-existing gaps and needs, which are now compounded as part of a humanitarian response. Additionally, humanitarian actors often have access to hard-to-reach populations, which can contribute and support demand generation and product uptake. Finally, it's easier to ensure alignment and agreement often in humanitarian response because we have built-in coordination architectures that drive both our humanitarian programming and our funding structures. The last thing, which I think is one of the biggest potential areas that humanitarian response can contribute to these conversations, is through our purchasing power. Humanitarian actors have huge purchasing power, especially when you look combined to the different international NGOs, UN agencies, and other actors that are procuring commodities from either international or local manufacturers. We can procure internationally, ensuring that the wider international market can meet certain common standards, which could then benefit the wider populations beyond just those surviving humanitarian crises. We can also similarly at the local level, create standards that are reinforced to help the local market go into the direction that we would want it to go, whether that's for quality, sustainability, or availability of different kinds of products. We can also support local mom and pop shops and suppliers by working with them through cash and voucher assistance, helping with demand generation in hard to reach areas where it's really local sellers that are able to reach that population more sustainably than maybe manufacturers or wholesalers. All of these things can aim to help improve the quality, ethical business practices, things like green adaptation, et cetera, as well as market availability. Next slide. One important consideration as well is how we can learn from other work done by other sectors. For example, a lot can be learned for the work around contraceptive uptake in programs globally, and particularly the role of humanitarian actors. While there are many parallels with contraceptives, I can give one example. Looking at increasing demand through applying a method mix model. In a humanitarian emergency, as a humanitarian actor, we would never look to introduce a new method as part of a sudden onset emergency response. However, there's a lot that could be done in preparedness, and then there's a lot that could be done after the emergency has passed to look at leveraging that moment to increase contraceptive choice and quality. As part of preparedness, private sector actors can work to register a wide range of products, while development actors can work to increase consumption and demand through advocacy and education. In an acute emergency, humanitarian actors can immediately, through international procurement, directly provide high quality products that were used by the population prior to the emergency. As the situation stabilizes, humanitarian actors can use their access to the population and advocacy to increase demand for a variety of methods through informed choice. Eventually, those potential gains made within the framework of the humanitarian operation can be built on again by national and development actors, continuing the cycle of progress. While humanitarian actors may not try to roll out a new MHM method in the start of a humanitarian emergency response, by leveraging the purchasing power and access humanitarian actors have, we can work to build this demand similarly for high quality products, which can lay that same foundation for supporting systematic progress and change. Next slide. The humanitarian sector has gradually come to recognize the need to come together to address these persistent challenges in menstrual hygiene management, and the potential to drive more sustainable change when we coordinate efforts. UNFPA and UNHCR took the initiative at the Global Refugee Forum in 2019 to make a pledge to work together to structurally address these bottlenecks. Under this commitment, we co-founded the Menstrual Hygiene Management in Emergencies Working Group to come together to operationally improve intersectoral programming on MHM in emergencies across the main intervention areas, including supplies, supportive infrastructure, information, education, communication, and enabling environment. Through the establishment of the MHM and Emergencies Working Group, we've worked to create the conditions to address the gaps we have in MHM and emergencies. We did this by creating a platform where everyone who has a role to play has a seat at the table. We're able to bring together different organizations and sectors in alignment and build strategic relationships with the humanitarian clusters, where we can ensure that whatever we develop is mainstreamed back into the wider humanitarian infrastructure of prioritization and funding. For the supplies group, we work to increase the quality of menstrual products and supportive materials distributed in humanitarian contexts and ensure the adoption of and harmonization of quality specifications. Among some of the work we have focused on, we have developed common standards for international and local procurement for menstrual hygiene products, with a focus on quality, ethical procurement considerations and compliance with SDG-related indicators, and environmental sustainability. We've looked at how we can harmonize these specifications to build sectoral acceptance of these standards. We've shared the standards with other humanitarian actors within and without UN agencies to look at ensuring consistency when we're delivering the same supplies to the same populations. We're also, for the first time, consolidating procurement. UNFPA and UNICEF, with the support of UNHCR, are working now to establish for this first time joint long-term agreements for products to be made available globally for both UN and third-party procurement, be them government or NGO. Lastly, we're looking to build capacity for improved local procurement practices among different actors. How do you evaluate a tender? How do you conduct an analysis of a product to help build that standard even higher at the local level? I wanted to end my presentation by saying that while we have a piece of the puzzle, we cannot do it alone without looking at wider sustainable development actors. On this slide, I have framed around the humanitarian programming cycle to look at how this can work. Preparedness, acute response, and post-acute response and recovery all have a different frame within how we can approach the MHM supply discussion. The goal in preparedness is to lay the framework for when a humanitarian crisis strikes to have baseline availability of high quality products available locally, a population informed about methods and choice, and a sustainable supply chain which can be resilient to shocks. Public sector development actors can advocate for national standards, increasing informed choice and demand generation for the range of products, reducing stigma related to MHM. National standard can work on national standards, standard budget lines, and the regulation of local markets, encouraging and investing in small manufacturers, producing high quality products. And the private sector can work to provide quality of products through a supply chain which targets markets in fragile and hard to reach areas, which may not often be the most profitable and easy places to serve. Finally, as part of an acute response, the goal of humanitarian actors is to provide, as I said, immediate access to the product in the short term, while working to build a favorable environment for the private sector to have a market of high quality product available locally and a population demanding a variety of items. As highlighted in this presentation, we can work through leveraging donor attention, conducting international and local procurement based on high quality specifications, conducting direct distribution based on informed choice and access to hard to reach populations, and leveraging cash and vouchers and market-based interventions to improve the local market. This will help us as a global community to sustainably address the challenges in menstrual hygiene management supplies beyond just a humanitarian response. Thank you.
Thank you very much, Danielle, for your presentation. And it's been really interesting to hear from your side how humanitarian actors through their purchasing powers can play a role in increasing the access to the types of menstrual products and also using it as a leverage point to push private sector actors to increase quality and the types of products that are available. And that actually perfectly links to the presentation from our next speaker. Tanya Mahajan from the Reproductive Health Supply Coalition is going to share some of the amazing work that's happened over the past year or two. And I would like to hand over to you to speak on behalf of this organization and the work that you've done.
Thanks, Adrian. And thanks, Danny, for a very insightful presentation. My name is Tanya Mahajan, and I'm the Program and Strategy Specialist with the PAD project. And I'm here today, as Adrian mentioned, as the co-chair of the Reproductive Health Supplies Coalition Menstrual Health Supplies Workstream. Quite a mouthful, I know. And I'm also representing my colleagues, Nancy Muller and Madison Chauvin, who coordinate the work stream along with me. Today, I'll be sharing some of the exploratory work that we have through the coalition commissioned over the last couple of years that can help inform the role of the public sector in menstrual health, in achieving menstrual health at scale. Next slide. So to just set the context, just wanted to share how we are approaching menstrual health through our work stream. So the overall goal for the work stream that we're looking at is to contribute to improved sexual and reproductive health through implementation of collective actions for increasing expansion and improvement of access to high quality menstrual products. And this we are hoping to achieve through 4 key outcomes, which are also the key pillars of the Reproductive Health Supplies Coalition. The first one being choice. Now, as Danny has also mentioned through her presentation, one of the key outcomes we are looking at is that menstruators have enhanced informed choice in managing their menstruation through multiple products, through a basket of products, through quality, that they have minimum quality standards, that there are minimum quality standards developed for all product categories for safe introduction. The third one being equity, that is, there is access to affordable and acceptable menstrual health products for all menstruators. And lastly, availability, which is that we have an improved understanding of the factors that limit availability of products to menstruators, particularly in low-income settings. Next slide. In keeping with, there's a slide missing, I think. Yeah. Thanks. In keeping with these outcomes, the RHSC commissioned a few exploratory diagnostic efforts over the last 2 years, which have helped inform the global menstrual health market ecosystem. The first of this was basically a study that was done by WASH United to really understand the impact of scrap the tax campaigns that have been happening across LMIC countries on actual affordability and availability of MH supplies. This looked at countries like Kenya, Tanzania, South Africa, Bangladesh, and others through qualitative data. The second was a supply that was commissioned and conducted by Man Global Health on understanding supply side factors influencing supplies access. And this was done in countries including Kenya, Tanzania, India, and Nigeria, but also gave a snapshot of the global supply side factors across LMIC regions. The third one is a research and advocacy project done by Development Solutions, Menstrual Health Alliance, India, and African Coalition for MHM, and really understanding the technical and process lessons for development of standards for menstrual health products, particularly in LMIC settings. And the last but not the least is an annual activity that RHSC undertakes, is to really understand the projection for RH supply needs in the coming years. This year, this activity, which is called the Landscape Assessment and Projection of RH Supply Needs, also included menstrual health products and has helped get an understanding of what the supply demand is likely to be from up till 2030. This study has essentially taken data from 129 low and middle income countries to see what is the global market snapshot, what is the number of menstruators, or the market volumes, and make an informed estimation of what the market size is going to be from about 2025 to 2030. Next slide. So, taking from the LEAP study, the global market snapshot is that currently there are around 1.7 billion menstruators in LMICs, and these menstruators are essentially using 1.2 billion purpose-made supplies. Now, by purpose-made supplies, we mean essentially supplies that are manufactured and transacted in the marketplace, including disposable and reusable sanitary pads, tampons, reusable cloth pads, period panties, and menstrual cups. And you also see a large volume of non-purpose made supplies that menstruators are using, which include, homegrown methods like cloth and others. The projected market size is likely to be 1.8 billion menstruators in LMICs by 2030. Next slide. The other emerging insights on the market, on the menstrual health market, particularly focusing on low and middle income countries, is that these markets are dominated by purpose-made single-use products and primarily disposable sanitary pads. Reusables are increasing, the adoption is increasing, both reusable period underwear, cloth pads, and menstrual cups. However, the current market share is less than 1%. And this is also because this market is currently largely fragmented. There's no coordinated advocacy. There's no large manufacturer which is putting in resources behind it. So there's a lot to be done on increasing access to reusable and increasing awareness of reusables in LMICs. We're also looking at doing menstrual waste volume calculations based on some of these insights, which will help us understand within WASH programming how menstrual waste management solutions need to be positioned. What is the magnitude of impact on environmental safety that these single-use products are having, and so accordingly sort of set up priorities related to menstrual waste management within WASH and other programming. Another insight is also that policy narratives in many of these countries, including Latin America, the West and Central African region, in South Asia, have primarily focused on free product distribution. And so haven't really looked at a holistic approach to market making and try to address specific levers which can address access to affordable products. Next slide, please. There's also high degree of trade flow that was understood that's coming from Southeast Asia and China to LMIC regions. There is a production hub specifically in South Asia in India, but all of the other regions have very high dependence on menstrual product supplies coming from these emerging economies. The cost pressures that were also identified, which make purpose-made single-use products unaffordable in many cases. One of them is that raw materials which are sourced from the US, Canada, particularly wood pulp, is becoming really expensive. Another is that in-country distribution costs are high, one, because the product is particularly bulky, and also because of fragmented supply chains in general. Decentralized manufacturing has potential. However, there are also concerns around cost because of low economies of scale, and also lack of economies of scale, and also quality assurance being missing in some of these smaller manufacturing facilities. There's also a need for harmonization of standards across geographies because they're highly variable in terms of technical benchmarks. And that has an impact on the fact that if one manufacturer is, say, manufacturing in one country and they want to export to another country, then they have to bear the cost of quality assurance in the other country as well. That either leads to high burden of quality assurance, or the fact that many of the products are non-compliant, both of which are unfavorable outcomes for affordable access. And so standards harmonization also faces gaps in evidence on safety of some of these materials, again, the burden of which falls on manufacturers and also leads to high degree of non-compliance. Next slide, please. So given all of these insights, and this was just a very, very brief snapshot of the insights, what we are recommending and what we think that there is a role for public sector actors to play is to really advocate for a holistic policy approach to menstrual health, and that menstrual health not be looked at as a siloed sector, but be linked with other sectors which have dedicated funding, resources allocated to them. So there are key linkages that can be drawn with menstrual health across a menstruator's reproductive life cycle with sexual reproductive health, education, gender, GBV outcomes, and also very importantly, WASH. MHH education needs to be integrated with conversations on comprehensive sexuality education, on maternal and child health, on family planning, and on WASH. So with family planning, we have a couple of great speakers who are going to talk more about that. So I'm not going to go into details, but for WASH, there's need for supportive infrastructure and waste management in homes, in schools, in workplaces that is essential for achieving menstrual health outcomes as well. So there is a very, very strong linkage here that needs to be looked at. There's also need to look at market-based models within a policy framework that address structural barriers instead of just that singular focus on distribution of sanitary pads or other products to supplement education. There's also scope for leveraging regional networks. There are innovations happening in small clusters, but there is scope for learning and for joint advocacy, say in the South-South region, in East and Southern Africa, in West and Central Africa, in the LOC region, in Southeast Asia. And all of these can really leverage some of the advocacy networks from these other sectors as well that are existing and are strong. Next slide, please. The other recommendation is on public sector actors contributing to market-making efforts. And this is essential for integration of choice for consumers. Can be done through, one, generating more data and evidence on performance, acceptability, and safety of all product categories, which can help safe introduction of these products. On either creation or enforcement of standards for disposable and reusable products, because safe introduction of a product into a market also requires that there are technical benchmarks in place for the same. And in most countries actually, a product like menstrual cups, and in many places also disposable pads and reusable pads, do not have existing standards. Also looking at taxation in a slightly more nuanced format where taxation levers can be used to address affordability of all products equitably and not just disposable sanitary pads. There's also scope for advocacy on harmonization of standards by contributing to country, regional, and ISO standards. ISO has started the process for creating standards for all menstrual products. And so there's huge scope for advocacy there. Also in investing in research gaps for contributing to these processes. There isn't actually any public data on material safety, microbiological safety. And so the burden of creating this evidence falls on the manufacturers. So there's need for the public sector to sort of take on this role and contribute to generation of this evidence. There's also a scope for building in these standards into local procurement processes. And the UNGM creating specifications has been a big step in this direction, which can be adopted by various actors working for the public sector to streamline procurement. There's also scope for encouraging domestic production in sub-Saharan Africa and Latin America, because there is high degree of trade dependence and there's no local clusters of manufacturing. Given the high dependence on wood pulp particularly, there's scope for innovation and use of local fibers and scaling some of the efforts that may be happening at small levels. There's also need to look at market models that can integrate menstrual health products with existing consumer goods supply chains as well as medical supply chains, both from the pharmacy route as well as the clinic route. And this can really address one of the levers that I mentioned, which is distribution costs. Given that many reusable products have high upfront costs, innovations and financing also have a role to play. Another area of evidence generation for really making informed decisions about market-based models is to understand, and this is not really known right now, is at what scale does decentralized manufacturing become viable? What are the complementary products that menstrual health supplies can be sort of partnered with in retail models, whether it's consumer goods, whether it's medical goods, whether it's health services, what really works from a consumer acceptance point of view? And which of these models contributes to high quality control of products? Next slide. And this is just a very brief summary of what the calls to action are. The reports for all of these studies and projects have been uploaded on the conference platform, and the ones that are not available in PDF, I'll be just putting the links on the chat box and you can access them. I want to close this discussion by sharing a quote which is mentioned in one of the articles in the Palgrave Handbook of Critical Menstruation Studies, which says that discussions on menstrual health are proving to be a potent entry point for reducing shame and ignorance about a host of issues, again, linkages to SRHR, WASH, everything pretty much. But challenges really remain to achieving standardized, coordinated, and sustainable programming. And that is where we at RHSC see the future of the public sector's role in making menstrual health more accessible and affordable for all menstruators globally. Thank you.
Thank you very much, Tanya, for your contributions and for your appeal to really start focusing more on the on the market making potential and the actions that need to be taken there. And for the public sector, one very important actor that has to step up is the government. What role governments can play in improving market access to menstrual products, but also meeting other requirements, including access to information, access to adequate infrastructure. And for that, today we have an amazing speaker here, Neville Okwaro, based in Nairobi, who's played a key role together with the Ministry of Health in the development of the world's first menstrual health and hygiene policy and strategy. Neville, over to you. Sorry, there we go.
Thank you so much, Adrian. I'm so happy to be here. I'm just going to take you through some brief snapshot of Kenya's MHM experience, and basically looking at what we've done and why we've been able to move at scale when it comes to matters of menstrual health management. Next slide. So basically, some of the stakeholders that have been involved in MHM work in Kenya, when you look at the government ministries, the lead ministry is the Ministry of Health. And also we've been working closely with the Ministry of Education. And these two particular ministries were very instrumental when we started the process of developing the menstrual hygiene management policy. Then on board came Ministry of Water and Sanitation and Gender, and the Office of the Attorney General in Kenya has to be joined to this particular process because they felt that we were going to create some structures and they will need legal advice in the developing of creating of those structures. Then it's also important to look at some of the government bodies which we deliberately decided to partner with, like the National Environment Management Authority, specifically for matters of disposal, the Kenya Bureau of Standards, the purposes of setting standards for some of the menstrual management materials, and also the Kenya Industrial Research and Development Institute, which looks at some of the products and how they can, the government can advise on how they can be made better. Then some of the UN agencies included the Water Supply and Sanitation Collaborative Council, which has now changed to the Sanitation Fund, UNICEF, and also UNFPA, and other NGOs, and also the private sector and social enterprises, which were very key when it and are still key when it comes to matters of MHM work. Next. So it's important to note that our interaction with MHM as a country started way back in the year 2004. At this particular time, Kenya was the first country to do away with tampon tax. And it was automatic that by the time we were doing away with that tax, it was going to reflect wholesomely on the costs. But there are still some other challenges that even though we did away with this tax as a country, we could not come to realize the cost that had been anticipated that is going to drop, hence making menstrual management materials accessible. So in 2011, the government again decided that we are going to do away with the excise duty of 25%, and also decided to do away with the VAT on now the raw materials that are used to make these products. Still, there was no great impact on the cost. And 2011 is when the country decided that they're going to that you're going to distribute free menstrual products to girls in public primary schools. At that particular time, there was no basis in law. Now come 2014, when as practitioners, we decided to look at our MHM structures. Government really never wanted to get into MHM per se, because according to them, it was more of a product-driven campaign. Most of the partners will recommend how we are going to deal with matters of MHM through provision of products. And at that time, government never saw it wise to get into that until 2015, when we started now giving structures to our MHM campaign. And in 2015, there are some 8 Kenyans that were taken in India for a training. And when they came back, they decided to organize a training for some of the government employees. And something landmark that also happened in 2016 in the month of May, we launched the Kenya Environmental Sanitation and Hygiene Policy. And one of the requirements of that policy was that as a country, we are going to develop a standalone menstrual hygiene management policy. So immediately after that, we got into trainings, and so far we've trained 181 government officers on menstrual hygiene management. These 181 government officers span from the ministry, the national government, and also the counties. And we've also trained the county first ladies, who are basically governors' wives. They have been instrumental in ensuring that we cascade matters of menstrual hygiene to the counties. At the same time, in 2020, we've also managed to launch the MHM. So basically in Kenya, when we talk about MHM, we are talking about a three-pronged approach to menstruation. We decided to approach it in this manner so that we do not look at MHM more as sort of products as the panacea for all the MHM challenges that we have. Because when you look at the myths and the taboos surrounding menstruation, it cannot be solved by product. So we decided, why don't we approach MHM differently? So we decided to approach it in a manner looking at a three-pronged approach, where we give all the relevant information to be able to demystify the myths and the taboos around menstruation. Then the second prong is looking at all the available options that are out there to manage menstruation, and including the enablers like watch facilities. We look at all these options so that we're able to promote choice when it comes to management of menstruation. And lastly, how do we safely reuse and also dispose of these menstrual products. Next. So based on this three-pronged approach to menstruation, we were looking also at how do we ensure that we have guiding principles that will be in the policy. And basically, some of the things that you're looking at, we realized that there are some groups that have been predominantly left behind when it comes to matters of MHM. So we are looking at how do we integrate these groups into part and parcel of MHM, and how do you ensure that we've integrated MHM into other existing programs, because it found a way easily in sanitation. Then how will we coordinate matters of MHM both at the national and at the county level? And how will we also ensure that we've developed a reliable research and learning base for MHM in Kenya, and having sustainable financing for MHM work? Next. So based on this, we basically came up with 5 policy objectives. Policy objective number 1, we are looking at all the legal and regulatory environment for MHM to thrive at the national and county level, whereby we are looking at the policies, the documents, the strategies that we are going to develop to ensure that MHM has thrived, including matters of financing and also coordination. Objective 2, 3, and 4 basically is just an adaptation of the three-pronged approach that we already had. Then objective 5, we realized that for us to be effective in our MHM work, we really need a strong evidence base, where we are going to have a strong monitoring and evaluation system for MHM, and also ensure that there is maximum accountability of policy implementation at all levels. Next. So some of the challenges that we've faced, even though we've launched the policy, still we are lacking funding from both government and partners, and funding has actually dwindled. When we were launching the policy, we were promised by government that government was going to give about $2 million purposely for the implementation of this policy, which was going to be increased as time goes by, but that has not happened. And right now, also with COVID, most of the funds have been channeled into fighting COVID. Then it's also important to note that some of the funding that have been received is normally geared towards how do we deliver products, but leaving other important aspects of MHM, such as information and also matters of disposal and others. Then there are also competing priorities. The same person who is supposed to oversee the implementation of the policy has other responsibilities. So sometimes MHM lags behind. Then due to COVID, some partners have also changed focus on their priority actions. And basically also COVID has affected a part of our work due to the restrictions that have been placed. Next. So what have we learned as a country? One of the things that we've learned that it's very much important to have that high level advocacy, especially to ministry leadership when it comes to matters of MHM. You might talk to the technical people about MHM, but when it comes to when the leadership of that ministry has not understood what MHM is, there's a high likelihood that will not make headway. Then also, it's important for us to underscore the importance of data and evidence in MHM work. And apart from that, how do we ensure that we've come up with some working formula? What really works? Is it a top-down approach or a bottom-up or a hybrid of both? For us, we've realized that it's important to have a hybrid of both, where we get lots of information from the bottom and it's going to reflect at the top. Then it's also important for us to have someone or other ministry that is going to take lead. When it's left without a lead ministry, then there's a likelihood that it might not happen. So who will coordinate these stakeholders? And the policy should be government-driven, not partner-driven. If it's partner-driven, there's a high likelihood that after the launch of the policy, it will still be left to the partners to implement it. Then we are also looking at integration. How do we ensure that we've integrated MHM into the various ministry work and also government sectors, such as sexual reproductive health and others? Then matters of funding, it's very important, even though that we rely on funding from partners, but it's also important that government has to set aside funding for MHM work, and especially for some of the work that is related to passing of information on matters of MHM. Lastly, on matters of consultation, ensure that you hear the voice of the voiceless. In most cases, we deal with MHM and menstruation issues amongst people that we interact with and people that we hear daily. But it's very much important that we look at MHM also amongst the people who do not usually get to speak about their changes. Thank you so much. Maybe just to add as I close, a policy that is not implemented is just like a piece of. This policy does not mean that we've gotten everything that we wanted. It's just the first step into other things. Thank you.
Thank you very much, Neville, for sharing your experience over the past, well, almost 2 decades in trying to mainstream menstrual health and hygiene into the work of the Kenyan government. And I think your last appeal is a very important one. We need to work on getting those policies in place and having the regulatory framework for others to thrive, but that's only when the real work starts. And then to look at what some of the other actors can do for us in realizing that, we have our final speaker, Elaine Tinsley from the World Bank, and she's going to speak to us about creating an enabling environment for scaling MHH from the perspective of the World Bank. Over to you, Elaine.
Thank you, Adrian. Thank you so much for having me. I greatly enjoyed the speaker's presentation, and I think they provide such a great in-depth insight into the activities and how do you really address MHH. So my name is Elaine. I'm with the private sector group at the World Bank, and MHH is surprisingly a relatively new topic for the World Bank in terms of how we've started to look at how do we incorporate MHH into our projects. A lot of times it's within the water sector, which has been doing a lot on providing facilities and constructing facilities with the education department. But lately we've also recognized that MHH is beyond that. So next slide. So one of the key issues that we're facing is that because MHH is actually a very multi-sectoral, the impact is very multi-sectoral. In education, it's quite clear what the impact can be on girls who have their periods. A lot of times they drop out of school, or even when they are in school, they're not performing as well. In health, there's also issues of menstrual-related syndromes, which impact school and work productivity. There's also issues of creating long-term fertility problems and also other urinary tract infections. To be honest, I think the health impacts are a little bit less documented, especially as they tie directly to improve MHH practices. And I think more can actually be done on documenting that. Because as Neville said, a lot of these times you have to make the case for why these impacts are quite important, especially when there's competing demands within the government, especially within the health ministry, of what to fund. And if the more evidence we can have on the health impacts, the more we can make the case for it. Waste is actually, I think, a new field where people are now getting into understanding the impact that menstrual waste products can have. And the solution is kind of a little bit twofold. One is on innovation in the product and creating more compostable products or reusable products. And the other one is on actually what do you do with the menstrual waste? How can you actually sort it? How can you manage it better? And then the fourth big bucket for impact is on the economic scale. As we mentioned earlier in education, girls who don't complete school or drop out, they suffer more economically, and so they miss out on earning and job growth potential. Next one. So when you have these sectors that are impacted in different ways, coordinating them to come together to be able to address MHH is a little bit more difficult, especially when the solutions to it are found in other sectors. So even though WASH is not a sector that's impacted, it is the sector that provides the solution. Education can provide a lot of the awareness activities, and the private sector also provides the product. So these are the sectors that provide the solutions. whereas the other sectors are the ones that actually get impacted by it. Next. So I think like within the government, that creates problems because as Neville also showed, there's a whole host of government agencies that have to come together. It's much easier to work within your own sector to solve a problem, but when you have to start coordinating with other sectors, this becomes a little bit more challenging. And so how do you start getting government buy-in? Because first and foremost, if you are going to create a more enabling environment, you need to get the government buy-in. And I think this is what we see as a lot of difficulties in a lot of countries, is because we're asking for such a multi-sectoral coordination, we have to have the buy-in, and you need to be able to build the evidence. First, you need to build the evidence on the problem, and then you also have to build the evidence on the solution. And between that, then you can have your theory of change that says, okay, if you have X number of girls dropping out of schools because of their periods, but if you do X, Y, and Z, this would reduce the dropout rates, and then this would lead to completion of school, increasing girls' earnings and formal employment. And in Kenya, for example, they did the study and they found that Kenya's GNP would grow by 3.2 billion, which is about 3% a year if all girls graduated from school. So we know what the impact is, but finding the direct linkages is a little bit difficult. And then if you can actually make the convincing case for the evidence on the problem and the solutions, you can set up the national policies and the sector strategies and you can get more buy-in on it. So on the next slide, I want to focus a little bit on one aspect, which is how do we support last mile providers? So we know the large producers, they produce in the urban markets and people might have access to it, but in the lower income communities, there are different challenges that they face. And so supporting last mile providers like social enterprises is going to be important. And there's four buckets that we see on how do we make these last mile markets work. One is increasing awareness. Second is increasing acceptance, increasing access, and increasing affordability. Those are our 4 A's. And I think this, when we look at what these enterprises are doing in this area, where is it that the government's role is to help create a more enabling environment? On awareness, we know that social enterprises have to spend a good portion of their budgets actually raising awareness, working with communities, teaching men about the benefits of girls buying menstrual product. But this is an activity that the government can also take on by using trusted teachers, national policies that diffuse information into the schools, having a menstrual health line. So this removes that cost burden from the social enterprises or last mile providers to the government, which can do it at a much larger scale. Acceptance, we talked a lot about quality standardizations in Tanya's presentation as well. And this is also important because you need to show value for money, especially in low income markets, where if you go into a product that does not work, you will not go back into that product and you run the risk of that. Using local brands is also a great way to be able to help socialize on the acceptance of the product. Increasing access to products. I think this is one of the most important things. Encouraging local production, facilitating new entrants, and encouraging multimodalities for distribution. And then affordability. I think this is another area where the government can actually step in a lot, whether it's having subsidized government schemes, subsidizing innovation in the space that actually reaches last mile markets, providing information on market research so that they know they have enterprises have the information on the market sizes and whether this is a feasible area to go in, then subsidizing it if it's not that feasible. And then also taxation policies, which we've already addressed on removing the tampon tax, but also on the value chain, as I think Tanya mentioned as well. So next one. And then besides helping support the enabling environment, what we've also found is it's important to actually monitor indicators for MHH progress. We've identified 6 different areas. We have a resource guide package, the Menstrual Health and Hygiene Resource Package Tools and Resources for Task Teams, which identifies, this is just a sampling of some of the indicators that we look at, because you need to know, you need to build the evidence for which interventions work. You need to be able to do cross-country comparisons, and you also need to be able to benchmark. So like if we can set Kenya, which has, I'm glad we were able to include the Kenya example, it's got a very comprehensive set. how do other countries compare to that? What are the next steps? What is the natural steps you need to take for an enabling environment for MHH? It's one thing to have national policies and strategies. It's another thing to have very defined roles and responsibilities. And it's another thing to have it embedded into your curriculum, teacher training curriculum, as well as your school curriculum. So when we can build up our indicators of this, we can also build up the evidence base. We build up the evidence base. This is something that we can use to deploy in other countries to build a case for why they should also be investing in creating a more enabling MHH environment. Next one. I think that's it. And then this is the 2 bar links for our hygiene, menstrual health and hygiene resource package tools, which kind of helps explain the different steps to go through, as well as the different indicators. And it's a great toolkit that we just recently produced. That's it. Over to you, Adrian.
Thank you so much, Elaine. And with that, we've come to the end of the speaker part of this session. Things take a little bit more time just because it's a fascinating topic and we have speakers with so much experience. But we still have a lot more very interesting people that have joined us for today's session. We have Kate Rademacher and Emily Hobbs from FHI 360. We have Frederick Chatfield from the Female Health Company and Maggie Kilborn-Brook from PATH. And these are all speakers that might have some experience in menstrual health and hygiene, but actually come from a very different background. And we've invited them specifically to look at what the menstrual health and hygiene space is doing through the lens of a different reproductive health issue or challenge. And to let them shed their light on what we're doing and what we can learn from the strategies that they employed to make their technologies or the challenges they're facing to scale those to increase their impact. And I would like to kick it off with Emily. Maybe a quick introduction from your side. And what I'd love to ask you is more or less related to the way that menstruation is often seen. It's really seen as a multidisciplinary topic, but at the same time, adoption of the issue among the different individual sectors differs quite significantly. And I think that Tanya already touched upon the fact that there's a lot of opportunity for different sectors like SRHR and contraceptives specifically to closer look at what they could do for menstrual health and hygiene. So in your view, what opportunities and benefits exist for actors working on contraceptives to take on menstrual health and hygiene? And what opportunities exist for us as menstrual health and hygiene actors to leverage your work by working with the contraceptive space? Over to you.
Thank you, Adrian. So my name is Emily Hopness, and I'm a technical officer at FHI 360 on the product development and introduction team. And thank you to all the speakers. This was such a fascinating panel. So I'm so excited to talk to you all. So we do a lot of work recently at FHI 360 about what we're calling family planning and menstrual health integration. So this is family planning taking on menstrual health and menstrual health taking on family planning, which is what you just said, Adrian. But first of all, I wanted to just say that there's a lot of opportunities and linkages between family planning and SRHR overall. And I think that's really important to acknowledge. And actually, Kate just put a reference in the chat to a recent paper called Seeking Synergies that goes into more detail about that. But just as an example, I think Tanya even mentioned this, in comprehensive sexuality education programs, it's important to both comprehensively talk about menstrual health and family planning and talk about how those two are linked. So understanding the menstrual cycle and how that impacts fertility and contraceptive use. But as far as linking up menstrual health and family planning in particular, there's a lot of overlaps and ways that the two fields can work together. So one example is in offering a full method mix. This includes fertility-based awareness methods. And so when you talk about fertility-based awareness methods, it's really important to understand the menstrual cycle. That's essential to that type of method. And so that's really a place where the two fields link up. Another example is medical barriers to family planning. So in many settings, when a user goes to a clinic and they want to start family planning, they have to prove that they're not pregnant. And that often means they have to show that they're menstruating. And so you're not always menstruating, and this is a huge barrier to accessing family planning. And so FHI has worked on something called the pregnancy checklist because pregnancy tests aren't readily available. And so this is a way to also sort of link up the two fields, making sure that menstruation isn't a barrier to family planning. And then finally, one area that we've done a lot of work in is addressing the issue of contraceptive-induced menstrual changes. So these are changes to a user's menstrual cycle that are caused by hormonal contraceptives or the copper IUD. It can be anything from reduced pain, more bleeding, less bleeding, shorter menstrual cycles, more irregular bleeding, a wide range of things. And these can both be a barrier and an opportunity. So a lot of users sort of view these changes as scary or dangerous or unhealthy. For example, a lot of users say, you know, there's bad blood building up in me if I don't have my period. And so there's a lot of work that needs to be done to sort of address these misconceptions and to educate people about contraceptive-induced menstrual changes so they know that they're normal. And we actually have a tool that acts as a guide for healthcare workers called the Normal tool. And we've done some research on this Normal tool, which is a job aid. And I'll put the link for that in the chat as well. And then finally, contraceptive-induced menstrual changes can be actually an opportunity because they include pausing bleeding, reducing pain. And so they can actually help to address menstrual symptoms and even some symptoms that come with menstrual disorders like endometriosis or fibroids. And so we also need to sort of increase education and reframe how we talk about side effects because there's actually side benefits to contraceptive use. And so that's another way that the two fields can kind of work together. And when it comes to contraceptive-induced menstrual changes, we've put together a task force and we're putting out a research and learning agenda. So please stay tuned for that. And if you're interested in that, put your contact information in the chat and we'd be happy to be in touch.
Brilliant. Thanks so much, Emily, for those insights. And I feel like your answer alone could warrant an entire session. So maybe we need to set up another one. For now, maybe over to Frederic. You work on behalf of the Female Health Company, and I know that you also have a whole background in private sector supply chains and all of that. But I'd love to hear from you, one, your role in this space, of course, but also if you can give an example of your experience on how you've been helping to drive adoption of the female condom with the support of public sector actors and ensuring that the demand that is then created is actually linked to a sustainable supply chain. And if there's any reflections that you have based on today's presentation in the way that you did that with the female condom and what we as the menstrual health and hygiene space could do to adopt some of that. So over to you, Frederic.
Okay, thank you very much, Adrian. And again, also for me, thank you so much for having me in this conference. We're really pleased to be able to participate and to exchange ideas. And we should do this definitely more often. As Adrian said, my name is Frederic Chatfield. I work at the Female Health Company. We are the creator of the world's first ever female condom. And we're still the largest producer of the FC2, the female or internal condom. We are a private company, so we think we are one of the experts in the PPP, the private public sector partnerships, because we do that loads to get our product to people and to make sure everybody has a choice for whatever method they want to use for their SRHR. And really to answer your question or your questions, Adrian, there were quite a lot of questions in there. And what we have really seen when introducing the female or internal condom, which was of course a new product in the world about 30 years ago, is how important it is to link supply and demand. And today we've heard a lot about supply and the challenges we face in getting products to menstruators and providing access, but we have really found that supply is only half of the picture, if you like. Demand is, of course, the other half. And in the past, I think we the female health company and in the field of the female condom introductions, mistakes have been made when large campaigns were done and advertising and the real awareness and demand creation activities were done, but then nobody made sure that there was also supply available, or the other way around, when large amount of products were brought into countries without the programming behind it, and then there was a real mismatch of demand and supply, and that really doesn't help. Of course, you're advocating for your products, so that is really important. So then the other question was the adaptation with public sector, and what can you do to convince public sector partners? And again, we've heard acceptability a lot today, and that's really important, and really share evidence of acceptability. Every new market we enter, one of the challenges from especially the public sector will the products be accepted in our context, and we really try to tell them that the products is accepted in all kinds of different contexts. However, what's really important that when you go and explain about the product, you contextualize your training. So that's really important, the contextualization of how you do your demand generation. And there's lots of products out there where we can use. The other thing is how we work with public sector actors, really, again, just on the supply and demand combination. So we really help them with planning. When you do the demand generation, make sure you have your distribution in place. And there again, the Ministry of Health and other civil society partners are extremely important actors. We work together we really rely on the public sector to help us with the selection of communities for the demand generation. Where shall we go to? How can we reach people? And that is so important. And for me, a really good example is when we, for example, did some training in Zimbabwe, instead of just going to Harare and ask all the stakeholders to go to the capital, we went with the Ministry of Health and with some other NGOs out into the communities and spoke to the people there, and hence we could reach more people because people didn't have to travel, but also we could get really the local specifics and have more open discussions with the people. So, and again, the public sector is really crucial for us as a partner to make sure that they identify the right communities to go to. And for this specific example in Zimbabwe, we selected all communities where the DREAMS program is also active. So again, there's a real collaboration between different programs. And another question you asked about how we make sure the supply chain is sustainable, and if only we all knew. But for us, one of the things we do as a female health company is when we do our demand generation, we really focus, of course, a lot on training about the product and about its benefits, and addressing the myths and misconceptions, as we heard today as well, again, where there's a lot of overlap. However, we also focus on training healthcare providers on how to order their products. So we will take into account, again, the local context and the local supply chain mechanisms, and we will make sure we train the right people on how to order the product. So again, we do the demand generation, but we also make sure the tools are in place for to ensure their supply and distribution can take place. So some reflections on what I heard today. As already said, that there was a lot about supply, and again, I want to say, supply is really important, but make sure you have the demand in place as well. Very interesting when I heard Danny say that for manufacturers, it's really, for example, difficult to get access to humanitarian areas. Our experience is different because our product will find its way there via organizations like the UNFPA or other procurers who will deliver a package of products into humanitarian areas. However, the demand generation is then a real challenge, especially if they give a whole basket of products and there's no specific focus on our product. Neville, I mean, I think he can teach all of us how to really integrate different actors in the public sector. That was an amazing presentation, and just for me, a reflection on there. It's something we are seeing with the FC2 and the female or internal condom, which you might start seeing for you as well, is awareness is starting to be there, and people are aware of the product, and the myths and misconceptions are slowly but surely overcome. But what we see is there's still a big gap in knowledge in how to access the product. So we're really changing almost our messaging from not only raising awareness, but going beyond this, where the real gaps to access and what type of knowledge needs to be available to people to be able to have the choice to choose the method they want for their SRHR. I think I'll leave it at that.
That's a lot of great insight. Thank you so much for paying so much attention throughout the 4 presentations over the course of 45 minutes. I want to go to something which is maybe aligned or similar. I know that we have Maggie here in the room, Maggie Coburn-Brook from PATH, and she has decades of experience in SRHR technologies, and a lot of those come together in the work on a diaphragm, which is amazing, and I would recommend people to reach out to her separately on that. But built on the experience that you've had, Maggie, what do you think, or what was in your space the role of early private sector entrance into that specific market, and how do you think, also reflecting for us at the menstrual health and hygiene space, where we saw Tanya mentioning that only less than 1% of the supply is going to the innovators who are making the reusable pads, the reusable menstrual cups. How should the public sector relate itself to these innovators, work with these innovators, or what potential barriers might be we throwing up without even realizing it, that prevent these innovators from really scaling their technologies?
Great.
Introduce yourself as well.
Okay, great. Just to give you a little bit of context, as Adrian said, I'm a senior program officer at PATH. PATH is an international NGO with headquarters in Seattle. It's a group of global innovators. We work across 70 countries to accelerate health equity so that all people and communities can thrive. And the experience that I'm going to bring today is that I've been working at PATH for more than 30 years in the area of sexual and reproductive health. I work with the Medical Devices and Health Technologies Group, where we develop and advance technologies for women and children for use in low and middle income countries. And in that context, during that time, we've worked on the design, development, and validation, and now the introduction of a single-sized contraceptive diaphragm. Before the Kaya diaphragm came along, the whole product category of diaphragms was being allowed to die out for a variety of reasons. They were not included in international procurement by family planning programs. Providers were not taught about them, and few clinics provided them. But at the same time, women said that they wanted access to more methods that were under their control, that had few side effects and could be easily started and stopped using when they needed them. We thought that sounded a lot like a diaphragm. And so PATH embarked upon a process to understand what was it that made traditional diaphragms difficult to supply, difficult to provide, and difficult for some consumers to use. We used a user-centered process to develop a single-sized diaphragm that fits most women, making it easier to supply and provide. We worked with women and their partners and healthcare providers to understand how to make the diaphragm easier to insert, easier to remove, and more comfortable for both partners. Public sector funding from USAID and foundations supported the product development, design validation, clinical studies, consumer acceptability studies that were required for regulatory applications. We did country assessments to explore the feasibility of introducing the diaphragm in low and middle income countries. But PATH does not manufacture products. and we don't sell products. So we needed a commercialization partner who had the expertise to take on manufacturing, production scale-up, regulatory activities, marketing and distribution, to basically take the single-size technology and make it a commercial product. We found the perfect partner in Kessel Medintim of Germany, a company that's dedicated to marketing and distribution of sexual and reproductive health products in nearly 40 countries, primarily developed and middle-income countries. PATH has worked with Medintim to develop partnerships and explore opportunities for introduction of the Kaya diaphragm in low and middle income countries where diaphragms have not been available in decades. So introduction of the Kaya diaphragm is not like introduction of just another contraceptive method, another IUD, another oral contraceptive. This is actually an opportunity to explore introduction of a whole new product category to women. And so I think those are some of the similarities that we might see with menstrual health products. For the panel today, I've been asked to share about my experience over the past decade working with Medintim to advance introduction of the Kaya diaphragm. First, in terms of private sector entrance to the reproductive health market and how the public sector can work with those innovators, the first thing is it takes a circle of champions to develop and introduce products. Some initiatives may start with the public sector. For example, the public sector may identify a health need. Other initiatives may come from the private sector, an idea or an inspiration for a new product. But ideally, the public sector and the private sector need to work together. No one partner can do it all. Product development is difficult. Product introduction is even harder. At PATH, when we're developing partnerships, we're looking for partners where there's good alignment with our goals and our vision. And this means that we need to understand what we're trying to achieve, and we need to be able to articulate that. Then we try to find partners who are excited and passionate about those same goals. In building sustainable markets and in any partnership and collaboration, it's important to know what our strengths are and what the strengths of our partners are and who's best positioned to move an activity forward. We need to have a roadmap of what is the current situation, agree on the direction we want to go, identify the obstacles and gaps that need to be addressed, and then agree on the key activities that we think will move things in those directions. And we need to be flexible as new information comes forward. What I've learned working with Medintim is that there are many small private sector companies that are committed to providing sexual and reproductive health products to women in their communities. Some of these are also proficient at manufacturing products, getting them registered, and moving products around the world. They often are able to move more quickly than the public sector. They are good problem solvers, and they have to work in an efficient and a sustainable manner. Adrian was also asking, what are the particular roles for the public sector and what are the particular roles for the private sector so that we can understand our relative strengths? I'd say the public sector can help move new initiatives forward, like creating a new contraceptive diaphragm that responds to the needs of women and providers and the healthcare system. The public sector can reduce the risk of product development and bringing technologies forward to a point where a private sector partner may find them attractive. The public sector is uniquely qualified to bring alliances, partnerships, and access to research partners, ministries of health, access to various user groups, and to other stakeholders that private sector partners may have difficulty accessing. The public sector is well positioned on issues of policy, advocacy that are required to create an enabling environment. We're good at asking questions. We're good at identifying gaps that need to be addressed and creating evidence and frameworks. We're good at doing research and creating evidence and creating tools for introduction. But the private sector has specific expertise in manufacturing, regulatory, marketing, distribution, understanding the needs of consumers. They may be more nimble than the public sector at making decisions and moving forward. They have to make decisions based upon what is efficient and sustainable. We don't want to create duplicate systems. That's not efficient. What we want to do is leverage the strengths of the partners to achieve health goals and improve women's access to sexual and reproductive health products. Given the increased interest in the SRH field in building sustainable markets, we think that leveraging the skills of the private sector is important to moving forward, to moving from lots of small pilot projects, which kind of sounds like where the menstrual health field is, to scaling up and expanding access to these products to better meet the needs of women and girls. Thank you.
Great. Thank you so much for that insight. And again, as I mentioned, there are too many people with great experience in here to make it fit in an hour and 15 minutes. That means that we're already 5 minutes over time. Now, there is still a question I would like to ask Kate, but before I do that, I want to be respectful of the time of the speakers, of the other panelists, and of course the audience that's been here. So if you would like to stick around, I know that the platform is going to shut us off in 5 minutes automatically. So we have 5 more minutes. But if you need to be somewhere else, if you've signed up to a different session, or if your boss is breathing down your neck, please don't feel obliged to stick around. But I want to thank you for your time and for being here today, for listening to all of us, and for starting a conversation that would require an entire week of sessions. Please feel free to reach out to myself, to my colleagues, to all the speakers and panelists that have been here today. And I know that both the recording of the session, as well as the different documents that have been referred to in the presentations, will either be available in the chat or in the separate document section of this page. So thank you so much. And if we haven't answered all the questions that came up in the chat that we try to follow up on, or that the speakers have followed up on, then please, again, we're happy to further engage with you. Now, let me take those last 4 minutes and ask Kate a question, because the term method mix has come up several times, and I'd really love for you to share what the actual concept meant when it was introduced and championed by the contraceptive sector, how it worked, the strategies it entailed in a snapshot, and maybe any key learnings for us as the menstrual health and hygiene space to look at how we can really improve choice of the types of products that people can choose from.
Yeah, thank you so much. And thanks to everyone. This has just been such a fabulous discussion and such a rich panel and panelists. Just in our last 2 minutes, I just want to really congratulate everyone for how choice has been a theme throughout this session. And I think that's really exciting and shows kind of the movement forward that we're having. As Adrian mentioned, we've been talking about choice and voluntarism and method mix in the family planning space for literally decades. And it's truly a pillar. WHO has recognized it as a human right. So I think the question I would ask you all to reflect on as we leave this session is, we talk about contraceptive method choice a lot. What does menstrual choice mean to you? And we are doing some thinking about that at FHI 360 with my colleagues, Emily and some other colleagues. If that's a topic that intrigues you, I would encourage you to get in touch with me and with Emily, because we're hoping to do some additional writing and thinking about the concept of menstrual choice. Our colleague Lucy Wilson's on the line, and so please follow up with any of us, Tanya. And one thing I'll just say that I think has been missing from this conversation today is the idea, I think we all agree that menstruators need access to products, both disposable, reusable, that meet their preferences, needs. Those needs and preferences may change over time, that are culturally appropriate and relevant, that also menstruators need access to high quality, safe facilities to manage their menses safely and to dispose of products safely. In addition, I think, again, something we haven't talked about as much today is the choice of how much, if and when to menstruate, including if and how much to manage menstrual pain and cramping. And that's something that hormonal contraceptives in particular have really a lot to offer to the menstrual health community, because of course, one of the things that some contraceptive products do, as Emily mentioned, is they change menstrual patterns, and that can include reduced bleeding or pause bleeding. And rather than seeing this as a negative side effect, we're really trying to kind of rebrand that as a positive side benefit. And so I think that can be an important part of menstrual choice as well. And in addition, the role of contraception in improving or helping manage menstrual disorders. So again, we're really excited about this topic. I can put my contact information in the chat and look forward to really moving that discussion forward for those who are interested as well. Thanks, Adrian, for having us.
Right, within time. Well, the platform is going to cut us off any minute now. So again, a big thank you to everyone who participated. I look forward to engaging with you in the future. And if people have anything they want to follow up with us on, then reach out to us on email. I threw my email address in the chat. Thank you so much and have a lovely Monday and a continuation of your week. That's it.
Thank you, Adrian.